So hemoglobinopathies, what exactly are they? Since we're talking about it's basically a group of disorders, just exactly how we were talking about. We can categorize these as far as, like we said, like as far as microcytic, hypochromic, normocytic, normochromic. We usually put the hemoglobinopathies into the normocytic, normochromic anemias category. So this is going to be the first one that we're going to be discussing. So what they are is they're basically disorders where the production of normal adult hemoglobin is partly or completely suppressed or replaced by a variant hemoglobin. So what we're talking about in this case is that the structure of hemoglobin is abnormal. So in this case, what we're saying is that we know how the globin chains are formed and create a hemoglobin. We have four different globin chains that make up a hemoglobin unit. So something is wrong within each one of those globin chains. So something, for example, one of the amino acids in that globin chain is abnormal. That throws off the structure of the hemoglobin, and we create a new abnormal kind of hemoglobin. So what we're saying is that there's a qualitative disorder with hemoglobin. So in this case, that's what these hemoglobinopathies are. These hemoglobinopathies are basically, there's some abnormal structure to that hemoglobin. So the way that we can categorize them is they're inherited abnormalities of the structure of one or more of the globin chains. It's an inherited abnormality related to the rate of synthesis of one or more of the globin chains, and it's failure of the normal switch from fetal hemoglobin to adult hemoglobin. So just kind of like I was saying, we can basically put these hemoglobin disorders into two main distinct categories. We can either put them into the categories of qualitative disorders, which is what we refer to as hemoglobinopathies, and again, there's something structurally wrong with the hemoglobin. Then we also have the quantitative disorders. For some reason, there's something wrong with one of the synthesis of the chains. So we're not making enough of one of the chains. So in this case, if we're not making one of the chains, then there's a quantitative disorder, not a qualitative. So the quantitative disorders, we identify them as thalassemias. So that's going to be the next lecture that we're going to discuss next class. It's going to be the thalassemias, but today we're just going to focus on the hemoglobinopathies. So qualitative abnormalities are located in the globin structure, and it's usually going to be involving the beta chain in this case. The heme portion of our hemoglobin is normal. So the protoporphyrin ring is fine, because remember, if we have an abnormality with that porphyrin ring, we call those disorders porphyrias. Okay, that's because there's something wrong with the structure of that protoporphyrin ring. In this case, we're talking that there's an abnormality with the globin chain. So we're going to see that that abnormality in the globin chain creates an abnormal kind of hemoglobin in this case. So it arises from one single amino acid substitution. So we're not saying, so remember when we were talking about those globin chains sometimes are like 146 amino acids long. So it's just one of those amino acids that's abnormal, and it creates an abnormal hemoglobin, and that's what we see in these hemoglobinopathies. So it may or may not cause abnormal laboratory test results. So the most important hemoglobinopathy that we're going to see is going to be sickle cell. So we have two main kinds. We have sickle cell trait and we have sickle cell anemia. So basically, what is the difference between it? Sickle cell anemia, when we look at it, it's either a heterozygous or homozygous disease. If you're heterozygous, it means that only one of the alleles in your chromosome contains the abnormality for sickle cell. So that means that you're a carrier. So that's sickle cell trait. So that's going to come with very, very mild symptoms. Usually it's never going to show any sort of signs or symptoms at all. You're just pretty much a carrier. We're going to be the ones that actually show sickle cell disease. It's when you're homozygous, when both alleles are basically make you homozygous for this disease, and that's when we're going to see the really severe signs and symptoms for sickle cell. So that's when we're going to see really, really nasty abnormalities in the peripheral blood. So what the schematic is showing you up here is basically if we had two parents and both of them are carriers, meaning that they're heterozygous. So that one of the alleles and each one of the parents carries the trait as far as for sickle cell. So what is their probability of actually carrying on, or one of their offspring being homozygous. Well, as from what that shows you on the bottom, it shows you that there's a 25% possibility that these two carriers can potentially have a baby that is homozygous, or that's going to show sickle cell disease, or the full-blown one. So when somebody's a carrier, the way that we're going to identify them, if we're looking at the genotype of it, we're going to look at both of the alleles as far as what they're carrying. So for example, if somebody has both hemoglobin A and hemoglobin S, meaning that they're heterozygous, we're going to always call it AS. So if somebody's identified with the genotype AS as far as for their hemoglobin, they're identified to have sickle cell trait. But if we say that their genotype is SS, meaning that they're carrying both they're homozygous for the disease, it means that both of their hemoglobin alleles show the dominance of the S of the hemoglobin S. So we're going to call it SS for sickle cell disease, which means that patients are homozygous for hemoglobin S, which is going to result in a very, very severe kind of anemia. So the frequency, the majority of the population that is going to be affected by sickle cell disease or even sickle cell trait is going to be African Americans. So African Americans are usually going to be the ones that are going to carry sickle cell disease, which occurs in about 1 in every 375 live African American births. And sickle cell trait occurs in approximately about 20 to 40% of the overall population, and it's a worldwide disorder. It's not something where we only see that it happens in the United States, or it only happens in Africa, or it only happens in Europe. It's just something that's really kind of known to be worldwide. So how and why these cells sickle? So hemoglobin S is going to be the type of hemoglobin that we carry as far as for these patients that do have any sort of sickle cell trait or sickle cell disease. The hemoglobin S forms a point mutation for the 6th amino acid on the beta chain. That's definitely important to know, because what we have on the 6th amino acid sequence, or in the 6th sequence of the amino acid chain, what we have is we have glutamic acid. So normally that's what we have on in that 6th position on the beta chain of that amino acid sequence. But in this case, what do we have as far as for hemoglobin S? That glutamic acid is switched for valine. Okay, so just think of hemoglobin S, think of sexy val, hemoglobin S, valine. Okay, so what is the abnormal amino acid when we're talking about it as far as in sickle cell? Valine. Okay, so in that 6th position, you definitely get certification questions as far as what is the specific abnormality found in sickle cell. So it's definitely important to remember this as far as pathophysiology of sickle cell anemia. Patients who are homozygous for sickle cell may look normal when they're fully oxygenated. So what's interesting with these sickle cells is that when they actually oxygenate, they grab the oxygen from the lungs, they're going to carry it to the tissues, and once they carry it to the tissues and they drop off that oxygen, it becomes deoxygenated. When it becomes deoxygenated, it crenates, and all of a sudden it's going to lose its shape. So it loses its fragility, and it actually kind of becomes really stiff. When it becomes really stiff, it's not all movable the way that my red blood cell used to be when it was oxygenated. When it was oxygenated, it could fold in on itself, and then it could maintain its shape. However, when it becomes deoxygenated and it's sickle cell, all of a sudden it crenates and it becomes this sickle shape. And then what happens is that it becomes very rigid. It doesn't bend and it doesn't move. So what does that cause? So we can already think about it. What happens when I get to those capillaries? For example, when I only have a space that's only 5 micrometers in length, or a space that's only 5 micrometers in length. That RBC that is already created is not going to be able to bend in on itself to basically kind of move through that really small space. So then what happens? It basically blocks that airway, or the capillary. So it blocks that capillary passageway, and what happens? All of those rigid RBCs are basically going to start stacking up on each other, and then what eventually happens? They block that passageway. So then it's going to result in a pulmonary or in an embolism, which again is going to be like a blockage of that specific capillary. It doesn't happen in the arterial passageways, or it doesn't happen in the venule passageways, it more happens in the capillary passageways. So then we can see that it can cause like a stroke, for example, or an embolism as far as in the lungs, or even in the legs. All of those capillary passageways where they're really, really small, just think of basically these RBCs kind of like start stacking up on top of each other, and it starts blocking that passageway for any other red blood cells to flow through. So basically the blockage of that passageway is going to lead to a lot of these these problems. So that's what it's telling you right there. Cells become rigid, which are going to impede the blood flow to the tissues, so which is going to lead to tissue death, organ infarction, as well as pain. The sickling is reversible up to a point. So my RBCs will be able to go back to the regular shape once they pick up that oxygen, but they're not going to have as long as of a lifespan that they normally are used to. So we all know, of course, red blood cells last 120 days, but in this case, they're going to start condensing. So we're going to reduce the amount of their lifespan. It's basically only going to become maybe half of that, or even maybe a third of that in this case. So they have both, and in patients that have sickle cell, we're going to notice that they have both extravascular hemolysis outside of the bone marrow, as well as intravascular hemolysis inside of the bone marrow. So basically this is kind of like a schematic. It's kind of giving you an idea of what we just said. We have our normal red blood cells. Our normal red blood cells, what happens when they get through those small little capillary areas? They're able to bend in and fold in on itself and then move through that small little passageway. But as far as for these sickle cells, they're very rigid. They don't move that much. They're not able to bend. So what happens? These crenated RBCs eventually will be blocking up the passageway for blood flow. When it does that, my muscles aren't going to be able to get the blood and oxygen that they need. So then it's going to lead to tissue necrosis and tissue death, and also a lot of pain. So clinical signs usually appear approximately at about 6 months of age. They have all the physical symptoms of anemia. So again, fatigue, lethargy, pallor, all of the stuff that we pretty much already talked about with microcytic anemias and also the macrocytic anemias. Growth and sexual maturation slows. Crisis, whenever there is a crisis, is very painful. So just think, any time that a patient is going to go through, or an individual who probably has sickle cell, if they go through a crisis, what would be a crisis? Whenever we need a really high concentration of oxygen, or whenever my body senses that they're going to need a lot more oxygen. So that's obviously going to be in those cases. Anything that deoxygenates blood blood acts as a trigger, for example, like exercise, maybe illness, or even airplane flights. Usually patients that are suffering from sickle cell disease, they can't travel anywhere. Because remember the basic principles that we were talking about as far as our red blood cell counts. Our red blood cell concentrations depend on where we live because of, again, remember the oxygen saturation. So what happens for somebody who has sickle cell and they go to that one area where there's not a lot of oxygen? So then all of a sudden their body's going to go through an increased demand. So in these cases, it might lead to a sickle cell crisis. And then again, what's going to happen? Sickle cells get stuck in the capillaries, which is then going to block the airflow or the blood flow. And then again, all of that other stuff that we already talked about, which again can lead to a stroke. Majority of the organs are going to be affected. Usually, as far as for the liver, it enlarges, it malfunctions. There's jaundice, hyperbilirubinemia, where there's a high bilirubin concentration in blood. In the heart, we see cardiomegaly. So we start seeing actually a thickening of the heart, and also iron deposits occur in the heart. In the spleen, it enlarges, leading to infarction and also fibrosis. Eventually, it's going to shrivel and becomes non-functional. In the skin, we're going to develop ulcers. It's going to look jaundice. In the kidney, we're going to notice hematuria and eventually kidney failure. As far as in the lungs, we're going to see infarction. In the brain, it can lead to a stroke. Blood, we're going to notice a hemolytic anemia. And also as far as in the bones, it's a very painful crisis. So some of the things that we're going to notice as far as with patients in the laboratory that are suffering from sickle cell, we're going to notice a hemoglobin concentration of 6 to 10 grams per deciliter. Again, the kind of anemia that we're going to categorize these hemoglobinopathies into are going to be normocytic, normochromic anemias. We're going to notice marked anisocytosis and poikilocytosis. sickle cells and target cells, nucleated red blood cells, and with polychromasia, when we're looking at it in a differential picture, increased reticulocytes, basophilic stippling, Howell-Jolly bodies, and Pappenheimer bodies, and definitely we're going to see a leukocytosis. And again, remember, what is leukocytosis? It's an increase in the white blood cell count with the left shift. And then we're also going to notice a thrombocytosis with that as well. So one of the things, actually, right before I go back, if you kind of notice, or if you guys are following along, if you look at the picture on your left, on your right, again, why are we calling it sickle cell? Because the RBCs are taking on the shape of sickles. So, and again, if you guys don't know what a sickle is, of course, if you guys know what death looks like. So whenever you think of like the Grim Reaper, it's like the skeleton with the black cloak on, and then he's carrying the scythe. Yeah, so that scythe, the blade portion of it is a sickle. So it's one pointed end and one end is flat. So that's kind of how these RBCs look. They look like they have one pointed end, or they usually have two in this case. So the main way that we're going to identify or we're going to confirm somebody with sickle cell, we're going to do a hemoglobin electrophoresis in this case. We're either going to use either an alkaline or acid medium to separate the individual hemoglobins, and we're going to separate the different kinds of hemoglobins that we see. And of course, in patients with hemoglobin S, we're going to see a very high concentration of hemoglobin S in there. As far as for osmotic fragility, like we talked about before, that's going to be decreased. And remember, since these RBCs are a little bit smaller, again, it's going to affect their the SED rate. The ESR is going to be decreased in this case. And then again, we're going to notice the hemoglobin solubility test is going to be positive. So some of the other chemistry tests that we're going to notice as far as with sickle cell, lactate dehydrogenase is going to be increased. The bilirubin is going to be increased, as well as the haptoglobin. So make sure to remember, why is the LDH increased? We kind of talked about it before, and that was when we were saying that LDH is lactate dehydrogenase, and that's something that we can find inside of red blood cells. So if we have any sort of hemolysis going on, or lysing of these red blood cells, then it's going to release all of those components that were once inside. So lactate dehydrogenase was inside, those RBCs lysed, it releases it. So we're going to see a higher concentration of LDH inside of these red blood cells as well. Okay. So as far as for sickle cell anemia, what the treatment for it is basically we're going to try and prevent where it's all supportive therapy, supporting basically any of the signs and symptoms that the patient is suffering from. So as far as for supportive therapy, we're going to do basically prevention of infection, make sure that they don't get an infection, try to fight it off before anything happens. As far as reducing organ damage, hydroxyurea, it's believed to induce the production of hemoglobin F using chemotherapeutic agents. Avoidance of any situations that could cause a crisis. So again, like I said, how would we reduce that? Obviously by telling the patient that they can't fly or travel as much, or if they are, make sure that they're just basically, it's either going to have to be by car, but not really by flight. Minimize the amount of pain. Again, like I'm saying, suppressive therapy. Blood transfusions is another way. And the median life expectancy, again, is usually a full life at approximately about 50 years. Patients that are AS, so everything that we discussed prior to, that's for homozygous individuals. So it means that they both got the trait from both parents in this case. So since they got it from both parents, they're homozygous for it. In this case, they're heterozygous. One of their parents gave them the normal hemoglobin A allele, and the other one gave them the trait for it. So in these cases, usually patients often have a normal lifespan. Usually they're very asymptomatic with occasional episodes of hematuria where sometimes in a crisis, we might see that they have blood in their urine. Sickling can occur with drastic reduction of oxygen tension, such as severe respiratory infections, air travel with unpressurized aircrafts, anesthesia, or congestive heart failure can also induce a really extreme crisis. Exercise that causes a buildup of lactic acid can also cause sickling due to a lower pH. So again, it basically is just telling you that we really don't see critical signs and symptoms in patients that are just carriers. Usually when it's just in a really severe crisis do we actually see that the RBCs start to sickle in that case, and we can see it in the differential. As far as for laboratory features for patients in sickle cell trait, they usually show a normal CBC with very few target cells. Hemoglobin solubility test is going to show positive, and then the electrophoresis is going to show two bands, where we're going to have two populations of hemoglobins, both at the A and the S. So usually the A is going to look almost normal, and then the S band is going to look a little bit thicker.